Hi everyone, my name is Mackenzie Danker and I did my paper in PowerPoint on the refusal of care. Our broad scope of nursing practice requires that we have ethical, professional, and legal knowledge on related issues that are relevant to clinical nursing practice, and some medical and ethical principles such as autonomy, beneficence, non-maleficence, advocacy, justice, veracity. These all play a critical role in situations where patients or their family members are refusing treatment, along with determining if the patient has the capacity to be able to refuse care. The first step in regards to refusal of care begins with determining if the patient has the capacity to refuse. And capacity is defined as, by Leo 1999, as a person's ability to process information and make an informed decision about their care in a way that's in line with their beliefs, values, and preferences. And it's important to consider when a patient's refusing care in order to determine if the patient if their decision making is impaired or if it's just the patient exercising their right to autonomy. And capacity is different from a similar concept of competence, and capacity is utilized by the medical community to assist with healthcare situations and choices, whereas competence is a legal assessment of a patient's ability to make medical decisions that can only be decided by a judiciary system, according to Buchanan 2004. Competence is applicable to more than just medical decision making, such as the ability to enter a contract or prepare a will. And in order for a person to be deemed incompetent, it needs to be proven with clear and convincing evidence. In order to determine capacity, there's 4 accepted assessment components that are looked at. First is a patient must be able to express an understanding of their medical situation and the decision that they're making, and then any risks or benefits that are associated. And second, the patient must be able to communicate a clear, consistent choice without frequently changing their mind in regards to the decision. And the third aspect is appreciation. A patient must be able to apply the understanding of their medical situation to their own life. If a patient is able to explain the situation but unable to relate the understanding of their medical situation to their own life, then they're considered to lack that appreciation. An example would be a patient who's able to determine what a heart attack is but unable to appreciate a situation in which they are having one despite being presented proof. And then the fourth and final component is reasoning, and this refers to a patient's ability to conclude the consequences of their decisions and express an explanation as to why they would rather refuse care if they chose to do so. In the process of determining the capacity of a patient that wants to refuse care, there's many issues or special circumstances that can arise, and these require several special populations of patients to have some unique rules or exceptions, and these can include intoxicated patients, psychiatric patients, hospice patients or patients with advanced medical directives, and then adolescent or pediatric patients. The first one that I'm going to talk about here are intoxicated patients. Patients that are under the influence of alcohol or drugs may not have the capacity to make their own medical decisions. Therefore, there's laws that are in place throughout the states that allow for involuntary hospitalization of these type of patients, especially when they're at risk of self-harm. And this is in order to balance beneficence and non-maleficence in a situation in which a patient's autonomy is compromised. The laws, of course, vary by state. However, typically they allow for a temporary allowance of involuntary hospitalization and treatment until the patient's no longer intoxicated and any medical illnesses that have affected the patient's capacity to decision making has been resolved. An additional patient population to consider when determining capacity is psychiatric patients. Some medical conditions that these type of patients can have typically will interfere with their capacity to refuse care. However, it is important to remember that having a diagnosis of a psychiatric disease does not just automatically hinder a patient from having capacity. This is why it is extremely important to always perform a full assessment of capacity on every patient, including those that have psychiatric disease processes. If a psychiatric patient is refusing medical care and it's determined that their illness is impeding on their capacity to do so, then it's pretty straightforward that healthcare providers are expected to still treat the patient regardless of their refusal. And as similar to the laws regarding the intoxicated patients, there's also laws regarding psychiatric patient situations that also vary state by state, but they will also allow for involuntary holds in a medical facility when a patient's in danger of themselves or others, or they're unable to provide for their own basic needs. The laws, of course, limit the amount of time for involuntary holds and treatment, but assessment is done for the need for the hold by mental health professionals or physicians. But sometimes other professionals, such as the police, are also allowed to perform this assessment. Another important population of patients that refuse care are those that are on hospice or those that have advanced directives, such as a DNR or a DNI order. Research has shown that at least 42% of adults older than 60 years of age needed to make decisions about their treatment in their final days of life. However, 70% of those adults were found to have impaired capacity to do so. Hopefully, in most of these situations, patients already made plans with medical and or legal professionals to have their preferences put forth when they're unable to communicate. And sometimes these decisions are made with or without the discussion or input of a patient's family. So sometimes that can cause issues if the family member disagrees with the decision or had no idea that the patient had this type of advance directive or wanted these specific things done. And typically, patients that do have these advance directives in place, we would hope that there's really no difficulties in fulfilling their medical decisions that they prefer. However, some situations, it's still a problem because sometimes the advance directives aren't readily available, or the provider may not know if a patient has a directive, especially in a situation where the patient's unable to relay that information themselves. It's important that the patient and the patient's wishes remain the primary focus for healthcare providers, and the medical decision-making in these type of scenarios should be driven by any information that's readily available, such as if the decision-making must be deferred to a legally appointed individual, such as a medical power of attorney, or go off of the advance directive paperwork. Another unique population to take into account is minors. Apart from 3 exceptions in the United States, patients who are under the age of 18 do not hold any legal right to make medical decisions for themselves, and they require parental consent for medical care. The 3 exceptions include any minor that's been legally emancipated. They have full medical decision-making power in all situations. And also, every single state in the U.S. honors a patient's right to seek care without parental consent for any health care that involves sexually transmitted infection testing or treatment, pregnancy prevention with contraceptives, and pregnancy or prenatal care. And the third one is a mature minor doctrine that states that minors who present intelligence and maturity to make healthcare decisions for themselves can be deemed legally responsible to make their own medical decisions. However, these type of situations are pretty rare. For minor patients, parents or guardians of the patient are able to refuse care. However, in an instance that a adolescent or pediatric patient requires emergency care, and the parent, is absent or refusing care, healthcare providers are legally required to provide care regardless of the refusal. Clinically determining capacity of a patient to make medical decisions can sometimes be problematic, but many clinicians and other healthcare professionals prefer to use a focus history approach, and they aim in on components of capacity with open-ended questions with understanding, expression of choice, appreciation, and reasoning. There's also several validated tools that are beneficial for providers that help standardized decision-making capacity. And the first one is the MacArthur Competence Assessment Tool for treatment. This is the most well-known tool that providers use to set of questions to guide the interview, and has been shown to be effective. And an additional tool is the Assessment of Capacity for Everyday Decisions. This is a point-based system that allows for providers to perform decision-specific assessments. Despite these tools that are available, it is important to keep in mind that every situation is unique, just like with all those other special populations to consider, so they might not be able to follow this kind of approach. Now I'm going to talk about a couple different ethical principles because these all play a key role in a nurse's ethical decision-making and being able to provide high-quality, patient-centered nursing care. Each of these principles helps navigate through difficult situations that patients or family members might be refusing care. So the first one that I'm going to talk about is autonomy, and this is defined as the right to determine what happens to one's own body by making informed decisions about their health care. This was defined by Taylor, 2013. And a patient's right to be able to refuse care is founded upon this basic ethical principle, and Taylor, 2013, discusses in that article how healthcare professionals should not impose their own beliefs or decisions upon their patients and let them make their own decisions. Every individual has a right to self-determination, with patient autonomy being part of that. It is protected by law, and a key component of nursing ethics is formed by the principle of respect for autonomy. Nurses should be promoting autonomy of patients and empower them to make autonomous decisions whenever possible. And like I said, it is protected by law by the Human Rights Act of 1988 for individuals who are unable to uphold their right to respect for autonomy. They can take action against a healthcare authority for that. Advocacy is also an essential part of a nurse's role, and it's necessary within the ethical code of all professional nurses. Highland, 2002, describes advocacy as a professional responsibility to support a patient's needs and wishes. And this can be done through a process involving analysis, counseling, responding, shielding, and whistleblowing. Highland determines that there is a relationship between nurse advocacy and patient autonomy. According to the United Kingdom Central Council for Nursing, Midwifery, and Health Visiting, if the nurse does not feel that sufficient information has been given in terms readily understandable to the patient so as to enable him to make a truly informed decision, it is for her to state this opinion and seek to have the situation remedied. Two additional medical principles that help guide care are beneficence, which is acting for a patient's good, and non-maleficence, which is the act of avoiding harm. Sometimes this can be challenging for nurses to find a good balance between both of these, because these two principles are often viewed as separate ends of one continuum. But in an instance where a patient's unable to make an autonomous decision, it's then the nurse's duty of beneficence to act in the best interest of the patient, in addition to upholding respect for that patient as an individual. Additionally, veracity, which is defined as truth-telling. This is also important with informed decision-making, and it's an important factor of a trusting nurse-patient relationship. However, it can cause a dilemma for nurses when there's situations when telling the truth may cause harm to a patient. But on the contrary, there's also situations where telling a lie may actually do good. However, this counteracts the principle of veracity. Justice is fairness in nursing, and that guides the need for nurses to treat individuals equally. In order for nurses to treat patients equally, they must acknowledge cultural, social, and educational diversity and embrace appropriate strategies. Consent to treatment is fundamental to the nurse-patient relationship, and the acceptance or refusal of treatment is ultimately the patient's decision alone. Issues that are involving patient consent to treatment are becoming increasingly important as nurses are broadening their scope of practice. The Court of Appeal states that a patient who has the necessary mental capacity to make decisions can refuse to give consent with or without reasoning for doing so. And the court protects this right of individuals. And this is illustrated in a court case that ruled it is established that the principle of self-determination requires that respect must be given to the wishes of the patient, so that if an adult patient of sound mind refuses, however unreasonably, to consent to treatment or care by which his life would or might be prolonged, the doctors responsible for his care must give effect to his wishes, even though they do not consider it to be in his best interest to do so. I researched a qualitative study that did in-depth interviews. This was performed by Cleffens and Lewin in 2005, and it was performed in order to gain insight into the standards of rationality that physicians use when evaluating patients' treatment refusals. The study specifically focused on patients with cancer who were refusing a recommended oncology treatment, and interviews from oncologists and general practitioners. Overall, it seemed that physicians evaluated a patient's treatment refusal based on personal values and experience as irrational and difficult for them to accept, especially when it concerned a curative treatment. However, when treatment was non-curative, physicians found it to be less difficult to accept the patient's refusal. One physician commented on a specific patient's refusal of treatment and said, "If it is related to previous communication breakdown combined with an enormous amount of fear, thus preventing the patient from forming a good idea of what that cancer can do if it is not treated, and no good decisions are made, then I find it irrational, or at least something I would try to change." And then from a patient's perspective on refusing care, you have to get the chance, I think, the patient said, as a human being to be allowed to reflect on it, the treatment, to consider what are the consequences, and then only decide whether or not you can or want to do it. It's obviously clearly established throughout medicine and ethics and the law that competent patients have the right to refuse treatment. However, sometimes it's problematic even for healthcare professionals when the patient's refusal conflicts with our medical opinion. So in conclusion, ethical principles that we talked about, autonomy, beneficence, non-maleficence, veracity, nurse advocacy, justice, self-determination, these all play a role in the nurse's ethical decision-making and being able to provide high-quality, patient-centered care. And they all play a role in helping to navigate through difficult situations such as the refusal of treatment. Our primary duty as healthcare providers is to make sure patients are receiving the best possible care And the refusal of care does not just terminate that responsibility. It's still necessary for healthcare providers to advocate for the decisions and well-being of patients despite refusal of care. And if a patient is deemed as having capacity to refuse care, healthcare providers can still play an important role by sharing their knowledge and expertise and advice regarding the medical decision at hand. And we can pretty much fill gaps in knowledge and reassure patients about the different risks and benefits of certain medical decisions. And this can influence the patient's decision and facilitate better care overall. Even though refusal of care can be perceived by us as uncooperative, it's important to not consider it as such. Patients are typically making decisions in an unfamiliar, stressful environment. And sometimes in situations, the best care that we can provide a patient is allowing them to maintain their autonomy and make their own decisions, even if it's not what we agree with or believe in. And that's the end of my slideshow. Thank you guys for listening, and here are my references.